I am going to get us started. I'm going to talk about, in this session, I'm going to be covering and giving you information on what we call atypical dementias. So the phrase atypical dementias, oh, and just like all the other sessions, you will find the PowerPoints, if you're looking for them, on teepasnow.com/presentations. So they're there under the conference heading. So if you're looking for that, that's where you can find it. So this session is about, okay, so what if the symptom profile I am seeing, what if the combination of symptoms I'm seeing doesn't seem to be one of those more routine ones that were on the umbrella slide, Lewy body, frontal temporal, one of those guys, or it's not, doesn't look just like vascular, and it's not looking like exactly like Alzheimer's. Could it be one of the others? Okay, and this others is this huge category where we are looking internationally at somewhere between 120 and 215 types, forms, causes of dementia. So when we say dementia, we know that means certain things. When we say the word dementia, it means that we have a neurodegenerative disease going on. Neurodegenerative means that the neurons that are part of the system are starting to fail and die. So when we're looking for an atypical one, we're looking for either a cause or a form of dementia that's not matching up in its early symptoms. So we go to early symptoms and then we look at progression pattern. So where does it start? Where do we first start to notice changes in abilities? What are the first signals and symptoms and challenges that we're running across? Whether we're the person living with it or the person living around the person living with it, what are our first indicators? Boy, this is a little different than normal. This is the new thing that we're noticing. And then we want to look at, so over time, what's happening? What are we noticing over time then? So we're looking both at original sites of injury and change, but then where does it go next? How does it travel in the brain? And what does it do to the body? So we're looking at some key features that might signal to us what we're looking at. And it's not one of the regulars, it doesn't look like. And if the person is further along in the condition, like we've been seeing symptoms for something like 3 to 5 years, we want to go back and try to recall what were some of the very first things that we noticed. Because 3 to 5 years of symptoms in, we're looking at, typically we should be seeing some kind of progression pattern, but not always, but that in and of itself is an indicator that we might have a certain type of dementia. So the kind of things that we're talking about can be inside the big raindrops over there on the left-hand side of the slide. So we could have things under vascular dementia that are sort of unique. They're not the classic vascular dementia. They're not like a multi-infarct or a vascular that happens after a single major event, like a bleed or a blowout or a blockage. So it's not after 5 to 20 years post-stroke. It's something else going on there. So it could be subcortical, which means it's below the level of the cortex. So it's going to involve some more basic body system connections or something along that line. Or codicil, which is actually a genetic type of condition. So it could be one of those, but I'm not going to focus in on that because either we covered it under vascular or we would go investigate vascular and see if one of these guys pops up as a version. What we're going to be doing mostly is looking over on the other side of the handle of the umbrella, the ones that are more unique, less common, the ones that typically we might pick up on or we might not pick up on, because what we found is that many medical providers are barely aware of some of the details of those big raindrops, and they trained under a certain period of time where they have certain messages, and they're having a hard time doing the change thing. So when we talk about this other side, it can be really tricky. So what we know about the atypicals, one of the reasons it's called atypical is because it's not what we would usually pick up on as necessarily a dementia. or what we may expect with certain dementias. So what we might do is we might miss it, or we might think it's something else, or we might think it's just part of the person because it's taking place over the time. Sometimes we just think, well, that's just how, I mean, God, he's getting so, what the heck is going on? I mean, he just seems so, he doesn't care anymore. I mean, it's just really difficult because we're not seeing him show us, her show, you know, this just seems like they're changing. And I get that they're changing, but I don't see it as a neurodegenerative condition. I'm just seeing it as them doing something, them making choices, them choosing something, or them not choosing something that historically they did. Now, we might also believe that there is absolutely nothing we can do about it anyway, so why bother? Which unfortunately is all too often a scenario we see. Or it could be that we stay in seek mode for so long that we're searching so much that we don't have a response mode. So we're just simply looking for what the heck is this? And we haven't figured out that regardless of what it is, we need to develop some skills for all of these conditions. And there are certain things we should be doing regardless, and there are some things we need to do because we're experiencing a certain thing. And we just have a hard time getting out of that, but I've got to know what it is. I want to know what it is. I want to know what kind it is. Maybe I should get a functional MRI. Maybe I should go look at a PET scan. What was that new thing they were talking about? And we get so excited about the discovery, the hope that once I figure out what it is, what we're actually missing is what we could do about what it is. So we're going to investigate a little of some of these, but we're also going to be talking about in this session, so how do we respond when we notice these kinds of things? We've got to move out of this idea that, you know what, even if I don't know the name of it, if I know what it's showing me, I can choose my support based on what I'm seeing, hearing, and what the person is doing or no longer doing. What I would also say is the other phenomena, that we want to really keep paying attention to is, what are some of these guys? So I'm going to give you some names because what I want you to get familiar with is what people do, which is they throw acronyms at you. They throw letters out. And if you're not familiar with these lettering systems, this way of lettering, it can, in and of itself, you're spending, well, what's CTE? And by then they've already gone, whoa, way down the road. So I'm going to go over just sort of some of the naming, because once you start to get a handle on the naming, sometimes that can be helpful. So CTE, it translates into chronic, traumatic, encephalopathy. So I'm going to go ahead and give you a little language lesson. So chronic, what is it? What do you think chronic means as opposed to what's the opposite of chronic? Let's dig into what's the opposite of chronic, acute. So what does that mean, do you think, right offhand? Chronic versus acute. What's the main difference there? Long period of time. It's going on, and as far as we can tell, it's not resolving. So an acute thing would be like getting a cold. A chronic thing is having an allergy that you can't seem to figure out what to do about. Now, if you manage an allergy, it may be acute. You have an acute episode, but what we're talking about here is a long-term change. Okay, now the second word is traumatic. When you think of the word traumatic, what does that bring to mind? Trauma, okay, bad, an injury, yep. Do this, take your hand, put it up like this, and then go, boom, do that, whack something. But what I'm gonna have you do now is, I'll stop sharing for a second so I can show you very clearly. What I want you to do is take one hand and make it a shell, and take your other hand and make it a brain. Okay, so what you now have is a brain inside the skull. Now, what's really important to understand is your brain is supported a little bit by fluid, and they're called meninges. There's actually a covering to your brain that protects and keeps the fluid in the brain area. And that fluid is still cerebrospinal fluid, the cleaning fluid of your brain, which is in all the ventricles, and it's the fluid that's good for your brain, but it's also cleaning fluid. Now take your fist and put it right inside there, and notice your wrist. This represents the back of your brain where it goes down into the spinal cord, because your brain is anchored in the back, in that it goes to the back. You have your medulla oblongata, your cerebellar area, which is your balance coordination area. The medulla oblongata is the stay alive area. And then we get into the spinal cord. And anybody who's ever been around someone who broke their neck, okay, had an injury to the C2, C3, C4, you know that they can no longer live independently because they lose mobility and sensation below the level of the lesion, the damage. So your spinal cord is in that bony structure we call the spine, but it's structurally connected at the back of your brain. So now take your hand and your fist and put it in there. So what happens is traumatic means that this skull part, it's something. So it whacks something. What happens is when your skull whacks something, your brain bounces back and forth, because it's anchored back here. And so it does this damage, and there's blood vessels all over the outside. And so what we ended up with is damage. So what we were looking for was skull fractures. Those would be serious. And we would look for, if you hit it hard enough, boom, that the damage happened. We thought at first it was just going to be in the area where you had impact. So if there was a fracture, ooh, we really wanted to look carefully, because we figured this tissue and the blood vessels might be damaged. And if they were damaged, if there was significant damage, the person might actually go into a coma, or the person might lose ability and they might have scarring, and that's status post-head injury. What we realized over time is that what happens is there was damage to the back of the brain called a contracture, opposite side, because when you're anchored, there's this back and forth, sort of like if you tap a balloon, how it bounces back and forth. So your brain is like that. So what we have found out over the last period of time is those trauma, even if they're tiny little traumas, they don't have to be major, little traumas, they may be concussions, which means at first you may see a change in vision. Like they always go, how many fingers do I have up? What's today? Tell me what's going on for you. I mean, where are you? What just happened? They're doing that orientation thing. They're doing that vision thing. Can you hear me? What did I just tell you? They're checking out what your ability is right away after the incident, because the idea is if there was enough injury, we should see something right then. And that's true, but here's the tricky part. What can happen is the swelling can happen after the event. And the damage can be sort of a slower kind of damage. It doesn't have to be severe. And it turns out, we think that certain groups of people, encephalopathy, it turns out it's not just a temporary damage that the concussion goes away and you're fine. Like they're fine. They get back up, they finish playing the game. They get back up, they get up on the pyramid again and cheerleading. They get back up, they go back to wrestling. So what we're finding out is, ooh, man. And the NFL actually took a major hit on this recently when it was discovered. They sort of knew about chronic traumatic encephalopathy for a lot longer than they really put out. So we're going to come back to this one. This one is turning out to be a bigger category than we had hoped of atypical dementia. So it's turning out to be typical if you keep doing things that cause harm to your head and you have certain other conditions in your system, genetic maybe or otherwise, your risk of having this type of development of a brain change can be more common. The second one down there, called PCA, is another one that we used to hardly ever even bring up. Posterior. Anybody want to give me what you think posterior is? What's posterior mean? Back. So put your hand back here. Now, from everything you've learned, what does that tell you right away? This one's going to start with posterior. Vision. Yeah, something's going to change on your vision. Something about vision is going to start to be different for you. And the second one, cortical, means it's going to be in your cortex. So it's not a deep brain thing. It's the cortex, the vision cortex, the occipital lobe, atrophy. So what's atrophy mean? Anybody got that one? Let's see what your Latin is like. Atrophy, going away. It means going away or shrinking. So it's actually similar to encephalopathy, but encephalopathy means entire brain is shrinking. This one, atrophy, means your occipital lobe is starting to show this kind of shrinkage or change or less able kind of thing. Now, the next one down is a genetically coded condition, and there are others, Huntington's. Now, the phrase that people are familiar with are Huntington's chorea. Now, chorea is a dance, but it's not a kind of dance you want to do. Tell me what you notice about, let me take away the screen for a second so you can see me clear. And it's called writhing. The term is writhing. So it's an inability to coordinate and get my muscles to do what I want, but also my muscles are constantly doing something, so I can't make them stop. And it tends to be, when we look at it, it looks uncomfortable. It looks uncomfortable. And for people who live with it, it may or may not be uncomfortable, but for sure on the outside looking in, man, it's always uncomfortable. But their new normal is they writhe. I mean, they don't have the ability, but I've got to figure out how I'm going to do whatever I'm going to do with this thing going on, which often involves not just the muscles of my extremities, but the muscles of my trunk, my neck, my face, my lips, my tongue, not my eyelids. That's a sort of a different one. Contractures can sometimes form, but not initially, but over time you will see often the person is not able to move into full extension patterns, mostly because when we do this and muscles turn on, flexion is a more powerful system than extension. Adduction adding to the core of the body versus abduction moving away from the core of the body. And forward flexion is stronger than big extension. So it's the power of these patterns becoming more, but again, the hallmark of it is this writhing or movement. And now it's typically mostly just called Huntington's rather than Huntington's chorea, but it's still out there. It is still a phrase you're going to see frequently. And it's a genetically oriented dementia. We'll talk a little bit more about it. Now, the next one I'm going to bring up is actually now up for debate. This is one that we thought we had a handle on, and it's certainly been around a long time now. It used to have some different names, as many of these did. I'm going to go over some of those old names for things, because initially a lot of the things that we now call these things for where we find them and what's going on with them were named for the physicians that first discovered them. Not for the people who first had the condition that the physician discovered, but the physician's name. So Huntington was discovered by Dr. Huntington. Alcohol-related dementias were often known as Wernicke's or Korsakoff's, because those were the physicians who first discovered the various forms of alcohol-related brain failure or brain damage. And historically, we've always looked at alcohol-related dementia as a progressive. As we're learning more, we're not sure about some alcohol-related dementias. We are aware of some of them are probably going to stay in the dementia category, but some of them are not. It's toxin exposure, but it's continued toxin exposure that gets people, and what happens to the brain when it doesn't get what it needs nourishment-wise over time and doesn't build wiring structures that would be needed for typical function. Now, the next one down there is PSP. So it's PSP, progressive supranuclear palsy. Now, palsy, much as chorea, but palsy can be more of a shaking palsy, a rigidity, or more of a chorea. But progressive, it moves forward. Supranuclear, above the nucleus. Now the nucleus is the thalamic nucleus, the nucleus in the brain where there's a lot of wiring transitions, sort of like if you thought of a switchboard, the old operator switchboard in a telephone system where all the hookups have to happen. So it's above that the damage is done. We'll talk more about that one. Creutzfeldt-Jacobs disease. The more familiar that some people are aware of is sort of mad cow disease. That one's related to mad cow disease. Batten's disease. Now, Batten's disease is a relatively new one, and it's a children's or a juvenile and infantile dementia. Yes, even children can develop dementia. Not something we like talking about or even many people are familiar with, but it actually does happen. It can happen at birth, before birth, after birth. So MSA, multi-system atrophy. So we'll talk a little bit about the multi-system atrophy. So these two things are related, and the reason they're related is new research is showing both of them are related to synuclein malformations, alpha-synuclein protein problems, but where the protein problems are helps define which of these it is. And if you have Lewy body, it starts in certain areas of the brain and spreads in a certain pattern. If you have multi-system, there's a different startup pattern. So the other course that we're running right now is having one, getting a second dementia. And it turns out you can have more than one. Yay? No, not so much yay. So what I'm going to do now is dive into, oh, wait, there's others. So one of the tricky parts of this atypical dementias is we're talking about a wider variety, but we know less about some of the details of some of these because we're just starting to explore them. So for instance, what we know is that people who have been exposed to toxins, either heavy metals or pesticides, have a higher risk of developing dementia. Now, are they all going to develop the same dementia? Well, we've just recently really committed ourselves to studying this phenomena. And what happens if you have children who are exposed to arsenic or lead and you stop the exposure? Do you end up with a child who may have a developmental delay or a developmental issue, but they stabilize? Or is there a long-term impact that predisposes them to either the development of a dementia still from those heavy metals? Because one of the things about heavy metals is once they get in, it's hard to get them out of a human system. Mercury, lead, things like, as I said, some of the pesticides. Those are sort of the, ugh. We also have conditions that are primarily called white matter diseases, and multiple sclerosis is one of those. Recent studies have shown us somewhere around 40% of people with MS, somewhere between 5 to 8 years into their MS, will start to develop symptoms of dementia. But it's sort of a dementia that's somewhat unique to MS. It has characteristics that really relate to what else is going on with MS. So they may have some psychological or what we call emotional impact. So they may be more grandiose or not realized. In other words, they have damage in the prefrontal cortex where I should have the ability to be self-aware. I'm not. And so I think I can still do things that I'm not good at doing anymore. So what then happens is I get a motorized wheelchair because of my motor changes, and now I'm going out in traffic and I'm running over things and I'm not safe in operation because I'm not able to recognize what else has changed in my brain. And people around me are frustrated because it feels and seems like I'm not following protocol. And so people in this atypical dementia often get identified as non-cooperative, non-compliant, unwilling to follow recommendations. And so it's really frustrating because it's like, well, what we're actually doing is blaming them for the condition they have rather than acknowledging part of what the condition is an inability to follow through on what I would have been able to follow through on before. So, oops, let me go back. One of the challenges doing this the way I'm doing it is that if I try to follow the chat and I make a mistake, when I click on the PowerPoint, yeah, it changes the PowerPoint on me. Now, I want to point out two other guys that are starting to be recognized as, wonder what happens here. Tumors that press on the brain, but we can't surgically remove the tumors. So if you have a tumor in your brain and it's in such a location and it is pervasive, in other words, it's built into the tissue and we can't take it out, certainly you're going to have symptoms that relate to the tumor, but we also know that as it grows or as it expands and as it changes things, it will start to affect your cognition. And so is that simply your tumor, or are we seeing neurodegeneration? And so we now identify that you have a dementia secondary to the presence and growth of your tumor, and it will be unique to where your tumor is and where it's growing and what it's destroying. Normal pressure hydrocephalus is a condition where the fluid in your brain is building up pressure rather than simply fading away into the rest of your system. It doesn't exit the spinal cord and the brain through the ventricles like it should, and it builds up and it starts destroying the tissue of your brain. That one is one that we still are trying to wrap our heads around. Then we have things like depression, anxiety, post-traumatic stress disorder, schizophrenia. When you've had a chronic life situation with chemical imbalances in your brain due to mental health issues, what we're finding is that the risk of people developing dementia at younger ages is going up. And so we're starting to realize, wow, there is a connection between depression and dementia. There's a connection between anxiety and dementia. We're trying to figure out exactly what that is. Could it be related to cortisol levels, to low dopamine levels, to elevated or challenging serotonin? Wonder what all is going on here. But what we're finding out is this brain and the blood-brain barrier is not nearly as impermeable. In other words, things can cross it a lot easier than we thought it could. So viral infections, things that do happen, and what we're not positive about in many cases is cause and effect and resolution if we treat. So we got Crystal Jacobs again, this crossing the blood-brain barrier. That's that mad cow phenomena. When you eat brain tissue or body tissue or tissue that's been infected by this particular viral agent, and you take it into your body, you have a very high risk of developing a very rapid degeneration that comes. AIDS, when you have HIV and it's controlled, not so much, but then what you can get if you go on and off meds, on and off meds, on and off meds, which it turns out people are not doing at the level they used to because there's better support, but what you can start is a complex AIDS dementia. It's called AIDS complex dementia, and it happens for people with advancing from HIV to AIDS. And we would see that a lot back in the AIDS era. For those of you who are younger, you don't even, maybe aren't even familiar with that period of time. COVID and AIDS, starting to have memories for some of us. Then we have Lyme disease, which you talk to some folks and they say absolutely not. You talk to other folks, they go, yeah, except if you don't get it treated and it continues to be present, you miss that target thing with the infection, then what you can still have is that underlying infection. So we're finding out more about infection, inflammation, and dementia. So deep breath. Wow. How many of you are feeling like, I'm not sure I want to be in this session? How many of you are going, oh, well, it's not so bad. All right. So Emilio, do you want to see if Polly wants to come over here and join us as a panelist and see if we have anybody else familiar with us enough that they would be interested in being a panelist rather than just entering all this good stuff in chat?
Yep.
Or if everybody's happy being over there in chat.
Teepa, I have a couple of questions if you,
Sure.
okay. Someone was wondering if you have any information yet on the percentage of people with psychiatric illness that develop dementia.
Yeah, so we do. We're starting to gather some of that. And what we find out is that approximately 50% of people who hit 65 and have a life history of having multiple episodes of a significant depression, 50% of those folks will start to show symptoms of some sort of dementia at younger ages. So we're talking about 55, 65, 75, instead of more around the 85 area. So that 50% thing where we start to see brain changes that affect life. So when I talk about dementia, I talk about brain changes that affect life and how you live life. I'm not talking about what's your score on the mini mental, because the score on the mini mental, in my experience, doesn't have as much to do with how you're living life. And so dementia, by definition, is an inability to still continue to live life the way you've lived life in significant ways. Your day-to-day life is being impacted. Your ability to thrive is being impacted. So whether it's depression, anxiety, even schizophrenia, what we're finding is more and more people are surviving and being managed with their mental health conditions for much longer with treatment. But even with treatment, their risk of developing one of these dementias is significantly elevated as age is added into the mixture. So those are basic ideas, but we're still discovering things. Because this is the first wave of numbers that we've had. We also know that folks who got ECT, electroconvulsive shock therapy, in the 80s and early 90s may have a higher risk of CTE. And if we think about that, those of us who were around during that time period, one of the things that happened during early ECT was that people would go into seizing, they would seize, and what we would do is they would have seizures and their head would slam down over and over again. And so what we now are looking back and going is, uh-oh, wow, okay, so that's contra-coup head injuries. And some of these folks were receiving those treatments to keep them from committing suicide multiple times over that time period. And until we learned how to do ECT so that it was not possible for the head to do that, we had to paralyze the person so they couldn't do that, because otherwise the brain was doing what it knows how to do. That's an example of sort of a induced CTE, which again, that's the kind of thing we're talking about. So Polly, another question?
Yeah, someone's asking for any more information about progressive supranuclear palsy.
I think I'm going to do that one. If not, I'll send you some stuff afterward. I think I added that one to the mix, but I'm trying to remember which all ones I added, because there were a lot of them. And I'm trying to cover quite a few, some of the more typical atypicals, if there is such a thing.
Before we move on, can you just clarify what's the sort of age cutoff for young onset versus typical onset?
So young onset, if you look historically, it was 65. Current thinking, it's more 70 to 75, because what we're recognizing is as we've had better healthcare over periods of time, the age at which we start to see the impact of age alone, just the years on this earth, our exposure is becoming more variable. And so many people who are active in the field are using 70 as a cutoff point rather than 65. 65 is this arbitrary age we pick for retirement. I mean, it really is not. Classically, some of the changes that we see that are significant changes for the bodies and the brains dealing with the world and with intake and with absorption and with drugs and with chemicals, somewhere around 70 to 75 is more classically, but we can have some people at 55 who are showing this kind of phenomenon. So, you know, typically I think we're seeing more people moving more toward the 70 plus years of age. If you're talking about reimbursement services, you're talking 65, because that's what you can get reimbursed for, unless you do young onset, and recognizing then you have to go through special hoops to get reimbursement support for what's happening. All right, so the first one I want to dig into a little bit is this chronic traumatic encephalopathy. And for those of you who came on Sunday, you might have seen Stephen talk for a bit. He was somebody who ends up, and there was someone else who we've had on the panel who's ended up with chronic traumatic as being their diagnosis, but it wasn't clear when it starts off, and it rarely is. These repeated head injuries or concussions they don't have to be significant. So they don't have to be ones where you sought medical treatment for, or you were in a coma, or it was really seen. It could be a motor vehicle accident where you bumped your head on the steering wheel and you end up with a bruise on your forehead. It could be where you, oh my heavens, when you were a kid, you were an ice skater and you had lots of falls. So it isn't necessarily something that stands out. But when we go back and we check, it's like, oh. So the symptoms, classic symptoms of chronic traumatic will involve some frontal lobe issues. So let's go over what's in the frontal lobe. So it's going to be, take your hands and put them out in front of you. So let me just go ahead and go over what that might look like for people. So put your hands out like you're going to reach for something, and then grab something and go, whoa. So I want you to go, whoa. So it involves aspects of impulse control. I can't control my impulses. And those impulses might be what I say, what I look at, what I do, what I know isn't okay, but I do it anyway. I have a hard time pulling back from things, and I make really quick, but not very thoughtful. And so this will be a change in me. So think about the level that you operate, risk-taking. What's your risk-taking behavior? And then what happens is for these folks, what we notice is, wow, what in the world? We also want to look at then the second thing, take your hand back here. The prefrontal cortex, the part we're talking about, takes data from the occipital lobe, visual data, to it right here. The temporal lobes, auditory data. Parietal and frontal, sensory motor, from your body, so sensory movement data and sensory data from your body. Ooh, it also then gathers deep brain data, emotional reactions, heart rate, blood pressure, blood sugar, all this stuff. You bring it up, send it to the front of your brain, and the front of your brain, put it in the front of your brain and go, what it does is it allows you to take all this data from other areas of the brain and the system, think it through. It's the thinking part of your brain that allows you to reach a reasonable, logical, and rational conclusion based on the data. The front part of your brain cannot take data from the world. It can only take data from other parts of your brain. So what this means is, I'm not thinking straight. I'm ignoring some of the data. I'm missing some data, or my thinking doesn't seem to be reasonable and logical like it was before. So I'm saying things when you like I say, well, I don't want coffee. I don't like coffee. And what's your very first thought as you watch me take the drink? But you're drinking coffee. Guess what you will impulsively say to me? But you just drank coffee. Well, that's because it was in the cup. And your brain then says, I know, but you told me you didn't like it. Well, I don't. What's your next statement without thinking? Because I know it's coming. I can tell you right now, some of you are thinking it and you're having a hard time holding back. God, I hate that. Yeah, you want to say, well, then why are you drinking it? Well, because it's within arm's reach. And I'm being impulsive. So it's the combination of the impulsivity and the poor quality of thinking. You can see the illogic of it, and my brain is not picking up on the illogic because I keep forgetting what it's going to taste like every time until I put it in my mouth, or I'm not taking that taste in there. And yet when I taste it, I go, oh, this is awful. And before too long, when I keep going, God, this tastes like shit, what do you now want to say? Or what do you want to do impulsively? Let's be honest. What are you thinking? Take some, just take the cup away. I mean, you want to fix it for me, don't you? Yeah, but the problem is if you grab it out of my hand or you try to take it away, what are you doing? Because I'm not being logical. This is not a logical thing. This is a spontaneity kind of thing. I'm very spontaneous in this moment. And I'm impulsive. And then I'll turn around and say, I don't know why you gave me this coffee. I didn't. That's my cup. What I've got to say is when you have somebody in your life who has chronic traumatic encephalopathy, if I were to watch the two of you from the outside and not watch who started what, it would be hard for me sometimes to tell which person is the one that has the symptoms initially and who's reacting to the symptoms they have. Because chronic traumatic encephalopathy is so close to, I should be early on, I should be able to get you to I should be able to do this. And we're just doing this because we can't figure out the matchup. Because when I watch your brain do this stuff, my own thinking brain starts not to be so happy with what's going on. And it starts not working very well. Unless I get myself to realize what I'm dealing with is a chronic brain change. And I've got to adjust. I've got to do some adjusting here. So you're not liking that. Would you rather have water or do you want to finish that? No, it's a mess. Oh, so you don't like that. Yeah. Would you rather have water or do you want to finish it? Third skill in the prefrontal cortex is making decisions. Making decisions or choosing something. So the challenge is I keep doing what I'm doing without making an active decision to do something else because I've lost some of my decision-making capacity. And I keep spontaneously doing this thing that's not having a good outcome. So a classic example might be I drink a beer and I enjoy the beer. And without thinking, what do I do again? Yeah, go get another beer. And another beer. What's happening to my ability? What does alcohol do to the prefrontal cortex in general? Yeah, it anesthetizes it and it shuts off its efficiency. Its job is to do that. It's an analgesic and an anesthetizer. We used to use it in surgeries. That's how they would cut people's legs off in the Civil War, was you'd give them some alcohol and then you could do whatever because the brain isn't processing stuff. And so, unfortunately, one of the things that we might notice is an increased intake of things that make me feel good or take away pain. So what else does that possibly mean then? Because I want us to sort of think through this a little bit. What might I start doing without thinking? And if you point it out, it becomes a challenge situation. Yeah, so it could be sex. It could be drugs, it could be alcohol, it could be pain relievers, it could be sugar, cigarettes. So what can start happening is I'm doing things that are not me, but it only happens episodically at first. And so it's progressive, but at first it's not all the time. These are just little episodes. I mean, they just happen. And when they happen, after they happen, I might be sorry that it happened, and I promise I won't do it again. Because when I am me and I don't have this going on, guess what? I recognize that it shouldn't be done. But when I'm having the episode, I don't have the ability to do that. So that's that very tricky early kinds of things. It often gets missed. It's seen as willful because it tends to happen to people in their 40s, 50s, maybe early 60s, 30s, 40s, 50s, 60s, 20s, 30s, 40s, 50s, 60s, late teens, 20s, 40s, 50s, 60s. It can also be seen as a willfulness or a decision to do something. And it's really, at first, it's often misidentified as choice when what it actually expresses is lack of ability to make good choices that are consistent. So, yeah, the next part that's going to be a bit of a challenge is the fourth skill. Okay, so let's look at the fourth skill that's housed in the prefrontal. And I'm doing this in detail because some of these other dementias that we're going to talk about also have a prefrontal component, this front part of your brain component. So this is when you've made a decision or a choice. Now what you do is you initiate, you get started doing something. So pushing the start button, getting going, initiation, knowing what I'm going to do and start doing what I'm going to do and then do it accurately, going ahead and doing it. And then knowing when I've done it, I'm done doing it. I'm finished with doing it. So now I stop doing that and I move on to do something else. And I actively start doing that. And I do that accurately and I finish that and then I move on to something else. And so it's called initiation, sequence, terminate, transition. Initiate, get going, do it correctly, know the order of doing it so I do it accurately, finishing it, knowing when I'm done with it, and then going on to the next thing. So what do you think some of the things you might notice might look like? What might be some of the things that you notice when I'm starting to have issues in this area? What would be some of the hallmark things? So I make mistakes in sequence. So this is where I go to make coffee and I get everything right, except I never put grounds in. Or I go to make coffee and I forgot to turn the coffee pot on and I'm really surprised that there's no coffee. I don't understand it. Because when I do it, I don't realize I've skipped steps. And I don't always skip the same step because it's not like there's a memory problem. There's a sequencing problem. And that's very different than a memory problem. This is like where I keep skipping that one step. I don't. It's totally unpredictable which step I'm going to skip. But the other part is I don't start anything. I'm just standing there, sitting there, not doing things I used to be doing. You go, are you going to get up? Yep. Are you going to get dressed? Yeah, I will in a minute. And so it feels like I'm apathetic, but the challenge is I can't take the decision and turn it into an action. I just have ideation. I have no idea how to get going. And so you can deal with it a little different. Hey, Polly, come here, I want to show you something. First, I want to get you up out of where you are. I want to start with a simple single step thing. Hey, Polly. Now that was, do I get her attention? And then I give a motion cue. Come here, I want to show you something. I want to show you something doesn't require much of a sequence. And the automatic function, that cerebellar function, that's working fine. That isn't a problem. It's the initiation. I want to do something, but I don't know the first step. Well, the first step, I'm going to give it to you. But I'm going to make it feel like I could use your assistance on, oh, I need your help for a second. Here, come here, I'm going to show you something. 2 steps. And then I go, tell you what, can you pick that up? And what I'm starting to do is, okay, what's the sequence now? Here's your toothbrush. And if the person turns to me and says, well, what do you want me to do with this? Okay, this is more complicated than I thought, because when I handed it to you yesterday, guess what happened? You started doing it. And so at first, it's not going to be about the toothbrush. It's going to be, can you start breakfast? Well, yeah. Are you going to go pick up the kids? Yeah. Now, remember, these are younger people often. Are you going to finish that project? So this can be happening at work. I mean, this is high order stuff. And I can do a lot of things, but I'm dropping some balls every now and then. And I'm standing there and it's like, oh my God, what am I supposed to do if I have awareness? And that's the 5th skill. How aware of my changes am I? And with CTE, you got a 50-50. Yeah, I'm aware, or I have no idea. And so I think things are happening and I don't understand why. Actually, I do know why they're happening, because that stupid new computer or the stupid boss or you and your big mouth, if you would just shut up, I could focus, but I can't get it done because you're always yelling at me. And I describe things in excess sometimes because what I'm describing to you is I'm getting overwhelmed by incoming data. Go back to the second skill in the prefrontal cortex. Now, this last ability, so the fifth one, self-awareness, accuracy of self-awareness. Do I need assistance? Can I do this on my own? Do I know how to do this right now, or do I not? This one is so tricky with CTE because I can think I do, and yet when I go to do it, suddenly there's a missing piece that I may or may not know it's missing. So this one is tricky for me with CTE. And then the last one is the ability to see another person's perspective or point of view and realize that they're doing it and it's accurate. And if I have a different perspective, it's because we're seeing it differently. And what I can't understand is how it is you can't see it from where I'm seeing it. I'm really struggling with this idea of why can't you see it the way I see it? And I'm really frustrated with you because it feels to me like you're just not listening. So I'm going to pause here because for just a second, because I do want you guys, if you have any thoughts about that first element of CTE, and because that's an issue with many of these other ones we're going to talk about, we might be noticing frontal lobe issues. What's really important is we're noticing some of these other issues because that's the differential. We're going to see a lot of frontal lobe issues on almost every one of these atypicals. What we want to pay attention to is what are some of the other symptoms that are also accompanying it. So temporal lobe, language-related issues are going to be part of CTE. We might see a very rapid progression into what we call Alzheimer's type patterns. In other words, hippocampal changes. Learning and memory, learn and remember, find your way and keeping up with time. Or we might instead see a rapid progression into the frontal variant of FTD. So the kind of things that we would only see with FTD, but it's a very rapid progression. It happens quick. The third could be that we just switch over and we mostly have temporal lobe rapid progression. But we will also classically see emotional episodes that are extreme. They're extreme and I can't see anything but what I can see in those moments. And when I have those moments of extreme distress, I can become physically distraught. I can become emotionally distraught. I can cause harm to myself or someone else. Because when I'm in extreme distress in this little episode, it's just an episode, I can be actually very physical in my frustration with not being able to get it. I just can't get it. And because I'm still fairly young, fairly fit, and I've been a physical person, this could result in an episode that's pretty scary for folks in the moment. So giving me space and voice and appreciating, at that time, you're not getting much data in because my distress is really extreme. Trying to provide space and opportunity for the person to express what's going on, not trying to fix, is a really important thing to keep in mind. So I have provided in this laundry list sort of the full listing of what are some of the early signs: headaches, attention concentration, depression and suicide thoughts, but no changes in the structures of the brain. If you have FTE, you might start to see some structural shifts. In this one, you won't necessarily see that. Episodes of extreme impulsivity, episodes of paranoia or misinterpretation, changes in hyper or hypo attention, episodes of acute confusion, frustration, difficulty with tremors or coordination in skilled task performance. I just can't figure out the task. It's when I'm under stress, and then other times I'm perfectly fine doing things. Episodes of getting lost or disoriented or missing key elements of what I'm supposed to be looking for or doing. Hearing or vision impairment that comes and goes. It's like I can't figure things out and then I'm fine. And emotional lability. So those are the hallmarks. And what I did is I've provided sort of, when I went to find some resources that I thought might be helpful for people, these are some of the resources that I found that had enough data in them and had enough information in them that I thought they might be helpful. So that's what I did, is I sort of searched around for what I thought might help you.
Someone was wondering if antidepressants help CTE or make it worse?
Both. They can do both. What we would want is somebody who understands that a medication is only part of what we need to do. We need to also bring in talk therapy, and we need to skill up the primary people around the folks on how to do the support talk therapy that goes with this medication if we're going to try it. And we need to increase physical engagement in things that have value and purpose to the person, or the antidepressant isn't going to really have an impact. And typically there are some antidepressants that for individuals tend to work better, and there are some that have side effects or profiles that we want to avoid. And it really will vary dramatically. It'll vary actually dramatically by the individual, not by the CTE. Which is frustrating, because it's really then you often are looking at trial and error. So the idea of starting low, going slow, having a team that's involved in this, and making sure that we are tuning up and training up primary support individuals so that they're getting what they need, and they can give good feedback on whether or not this med is really making the difference we want, or it's causing things that we don't want, and we maybe should reinvestigate its value. Because it's going to be either value added or value depleted in most cases.
And how long on average people live with CTE?
That's really up for debate. It can be as short as 2 years. That's really, really short, but we have seen some cases that are that quick. We have seen it last 20 years. That's fairly unusual. What we will often see is a fairly rapid progression through early to middle to later state condition, and then staying longer in the later state, because what we have is we have somebody who is relatively fit and well other than this encephalopathy. So until the frame or the structures, the core structures of the system start failing, it's a tough one, because I watch the person that I've known really shift through the phases, and they spend more time classically in the ruby pearl state than they would necessarily in the sapphire to diamond to emerald state kind of condition. Often a fair amount of time in the amber state, which can be a challenge if they seek sensory. So the next one I want to bring up is, if you haven't moved, stand up and stretch, because that's what my alarm was going off for, is it's been about an hour and we need to move about a little bit, because this stuff will suck your brain in and you'll get to a place where you're tensing up, because I'm going through a lot of stuff relatively quickly. And I'm not going to get to everything. I know that. I mean, you should bet on that, because I'm trying to cover this umbrella phenomena. But get up and move about if you're just sitting there for just a few seconds. I'll talk and you can sort of move about a bit. This progressive supranuclear palsy is a subcortical dementia. So it's not so much highlighting the cortex, the occipital, the frontal, the temporal, and the sensory motor, the parietal and frontal. It's actually below that a little bit. And we're talking about people over the age of 60 as a rule. And the main thing that we notice at first is they're slowing down. They have a slowing of everything, and a weakening. So the hallmark of this one is a weakening. They just are weak. They're getting so weak, and they're slow, and they're weak, and they describe themselves. And so people are going, God, I'm just, it's just so hard. And so the weakening can even be in the larynx. So swallowing, speaking, but it's also slowing in the bigger muscles and weakening of the muscles. So my ability to move, my ability to sustain upright against gravity is starting to be impacted. So I have a harder and harder time expanding and contracting in order to breathe efficiently. And in this one, what we notice is tau pathologies, which is, we see it in Alzheimer's, but here we have huge number of tau pathologies, and they're spreading primarily through the deep brain and the cerebellum. So back in that back of your brain, and then they hit the prefrontal, the frontal. So they spread into those areas, but they start in the deep brain and the cerebellar area. And so what we see is these are people who are challenged by movement. So So falls and balance coordination, they're so slow, you can watch them fall in slow motions. They also have a very difficult time coming up against gravity or sustaining against gravity. One of the big differences we see in the 6 muscles that control your eyes. And so the hallmark of this is that when you try to get them to track with their eyes, they can't really track an object horizontally. If you try to get some tracking up and down, what you'll see is when you bring, it's called that doll's eye phenomena. So, you know, the baby dolls that have the lids that when you tip them, their eyes open or shut. So if you lay the baby down, what do the eyes do when you lay the baby down? They close. So when I lay back, or if I tip my head back, my eyes close. If I bring my head forward and upright, my eyes open up. So it's the doll's eyes, but it's an up and down movement, but I can't track. If you watch my eyes don't do it. My eyelids will do it, but my eyes don't track. So baby doll's eyes don't, you know, they don't move. The iris doesn't move, but the lids move. So it's called doll's eyes. And they have slurred speech, problems with breath. So this one can move very, very rapidly, primarily because look at what it's affecting. So tell me what you think some of the primary causes of loss of life are for this one. What do you think kills people with this particular dementia? What you got, Polly?
Lots of breathing issues and pneumonia.
Yeah, pneumonia and lack of eating. So what will happen is people will lose weight, swallowing, drinking. This is where some of the hard choices will be, do we put a feeding tube in, do we not put a feeding tube in? Because the ability to carefully control secretions. So this is a rough one because it actually happens relatively, for some people, very quickly. And for some folks, it's a slower thing, but still deciding what to do. If we haven't talked about it very early on, it can really be hard to be caught in that moment of feeling like, but if I don't do something about nourishment and hydration and keeping it safe, you're not going to be able to stay alive. And yet if I put that tube in, I'm going to get you to stay alive, but I'm not actually going to be able to stop the other things that are going on. So as soon as we can, recognizing what kind of thing this might be, and I will also tell you that this was only first initially looked at in the 1970s. So this is a new one. We've only been looking at supranuclear palsy for a brief period of time. It's almost always misidentified initially as Parkinson's. And because Parkinson's can go on for years, people initially are just thinking, well, treat it like Parkinson's. And again, it's that watching for that doll's eyes, watching for the softening speech, watching for those kind of things can be sort of some of the indicators that make a difference. And again, I've done some resources here. So I'll pause here for a second. Anybody have something that they want to ask or talk about with this one before I go to the next one? You seeing anything?
Someone said, what happens if given L-DOPA?
We won't see a lot of anything. So what classically we see is if they do try to use L-DOPA like you would with Parkinson's to help with tremors or to help with movement and bradykinesia, you won't see a major impact here. It doesn't really help that much. Often what folks were trying for a good bit of time was Ritalin. What we use with kids who have attention deficit disorders and hyperactivity, they were trying Ritalin to see if they could get the speed up, but it's also the weakness. It's the muscle weakness, and it's coming from the core of the brain. So some of that original stuff, I think people have pretty much quit doing it, but I suspect it depends on whether or not the practitioner who's seeing the individual recognizes what they're looking at, or they're still thinking it's something else. That it's chronic fatigue syndrome. It's the person is just apathetic and they're not trying, or they're depressed and we just need to treat the depression. because it does get misidentified, at least in the early signs and states, frequently with other health conditions, because it is this atypical, and it's not going to present itself as many dementias do, because there is not memory loss until much, that's not going to be one of the primary things you notice typically. So let's move on to alcohol-related dementias. And I've noticed at the top here, I've shifted a list: alcohol-related damage or alcohol-related dementia. And it used to be called, and may still in some charts be called, Wernicke's or Korsakoff syndrome. What we believe now, and one of the things we know, is that it's possibly caused, or it's tightly related to neurotoxicity and vitamin B1 deficiency and thiamine deficiency that happen when you consume a lot of alcohol. So if you use alcohol to try to manage anxiety, depression, social isolation, make you feel better. And so these are people who may have started using alcohol. Frequently, some of the folks we were talking about may have early in their life, as adolescents, as young adults, started using alcohol to self-manage social anxiety disorders, problems with being able to stay focused, and they would just take the edge off. But sometimes when people start doing that, the primitive brain says, yeah, great idea, have some more. And so that how much is the right amount and how much is now a risky amount? And your primitive brain gets used to something and liking something, and it tricks you into believing that more is better. Whether it's glucose or whether it's alcohol or whatever it is, it actually short circuits the system that should keep us safe and say a little is okay, a lot is not. It impairs too many things. And if it starts happening, and what we are most concerned about these days is binge drinking. Episodes where a lot is consumed in a brief period of time, and then there's a period of time where I'm not consuming. And then a lot is consumed in a brief period of time, because there's a greater risk of neurotoxicity or damage to brain cells and their connectivity. So some of the common symptoms that we'll notice initially is learning new things is really challenging. But guess what happens when you get challenged by trying to learn new things? What do you think your automatic go-to is? What's your best guess? I'm having a really hard time learning this. I just need to chill out a little bit. It's just making me really anxious trying to learn this. I'm just having a really hard time learning this. I feel like if I just had a drink. So what we end up seeing is that when we try to have people learn new, what they will do is have an episode of, again, that thing that happens. And so often by the time we finally clue into, wait a minute, I think we're actually getting brain destruction here. I think the hippocampal wiring is being destroyed at this point. I think the person is losing this ability. So they're not interested in valued activities, people, life. I mean, they get apathetic about that. They have impaired judgment and decision-making. They have emotional lability, all of which is pointing to the wiring in the prefrontal cortex. The wiring to and from the prefrontal cortex is being damaged. But the other place we'll see it is the thalamic wiring that goes from the thalamus to the cerebellar area, because the cerebellum is responsible for gravitational awareness and quick responsive movements, balance, and coordination. And one of the hallmarks is that I have what you notice about fine detailed movement. What do you notice about that? So what's one of the things that you might see? And you may think the person has been drinking. They haven't. What we now have is damage, and what we may or may not see is recovery. Now, this is where, is it a dementia, or is it just damage that can be recovered from? Well, if the wiring never formed, which is why we're particularly concerned about people who started using alcohol or another substance early, and with extreme use, because what we're finding is they never built the wiring into the prefrontal cortex. The wiring, there's a window of time as we're developing our brains, where that wiring is formed and those connections are made. So what we are finding is there's a high recidivism rate when that connection was never firmly formed in the first place. And it makes it so much harder to try to get this change to happen. That right now we're in a changing environment looking at alcohol and substance misuse or allocation use or abuse. Things are changing in how we look at this and how we understand it, because we're starting to appreciate the extreme role that the brain plays in this and the wiring of the brain plays. So what we're noticing here is this one is sort of in a state of change. As of right now, it is primarily still seen as a form of dementia for many, but for others, it's seen if we can catch it early and notice what's going on and start a program of support, we can actually get this to where it's not a dementia. There's damage, but there's not progression. Our challenge is by the time we typically notice it, there's been so much damage that now we are moving into, we don't know whether it's just alcohol-related dementia or they start to actually have the development of a secondary dementia. Because it's only recently we were curious enough to start asking these questions. So I'll pause there to see if, and I've given you some resources. This is sort of the latest resources that I could find, and these are all relatively new resources to help us really start to look at this question and how do we look at it.
Someone was wondering if there is a correlation also between other recreational drug use and also long-term antipsychotic use.
Yeah, so we're finding the same thing. People who are heavy users of marijuana, particularly THC. We're finding that group has that wiring thing issue as well. Cocaine, similar kind of wiring, but cocaine is a little more deadly. It actually destroys wiring. Similar but different than what alcohol does. We are also seeing methamphetamine, that kind of excessive use of something that's an artificial, and the opioids. Those kind of things that we're using, classically, when we are using them in excess, that is a really tough thing because what we're doing is changing the wiring of the brain. So we're doing brain change. The question is, can we resolve it if we catch it early enough? And anybody who's ever had the condition will tell you, man, it is always a work in progress afterward. Because it is a constant battle, a constant struggle. And if I start having a secondary brain change, it will be really, really important to understand that if I start developing Alzheimer's or if I start to develop a frontal temporal dementia and I already have an alcohol-related damage or a substance-related damage, as a helper, I need to be so tuned into that because if I'm not careful, I will forget about the wiring issue that was already there. And I will start thinking that I can get them to control their use of substance, whether it's cigarettes and nicotine, or whether it's marijuana, or whether it's alcohol. And what I'll end up with, watch my hands. This is where people say they get so violent. And it's like, well, what we're doing is we're trapping them in a system that they don't have a strategy to work with now. And what we're often looking at is we miss the second dementia jumping on. And so now we have the alcohol or the substance that they've been trying to manage. And it was always trying to manage. Anybody who's ever had this issue in their life, from now on, you're trying to manage it. And it's a day-to-day effort to manage it. You never lose that desire to go back to the easy ride. Because when you have the anesthesia on board, man, you don't feel pain. And you feel like you feel better, even though you know it's dangerous, it destroys your life. It is so hard when your brain isn't at its peak. And what these other dementias do is rob you of the peak. So for me, it's a really important phenomena to keep in mind and also to help helpers appreciate, because the systems where we put people in systems where they don't have access at all. And then what we do is put helpers in harm's way, because the helpers have access to things that the people who are in the systems don't. And so we're setting people up, and I don't have an answer, but I do know that what we've classically done before isn't particularly helpful to the people family members and staff who are placed in settings where people are stuck or have access, either one. And we don't have systems that are really addressing this well. And I think it's a really underserved and misunderstood population of helpers and people who are living with conditions. And there's a lot of judgment around it, not a lot of curiosity. And I think that makes it really hard. Huntington's, Huntington's disease is genetic. And it's come to light in the last 30 years or so that Huntington's it's called a dementia that comes with, if you get a gene from a family, a mother or a father, you will develop Huntington's. And so it's called a dominant gene. So that if it happens, you get it. And if you have children, you have a 50-50 risk of passing it on. Now, what that means is that many families who are dealing with Huntington's by now have gotten to a place where they're making active choices about whether or not to have biological children, or whether they even want to have children. But it is sort of one of these things where genetic counseling is usually part of the diagnostic workup, because figuring out what does this mean for the person, but also because we're talking about people who are 30 to 40 years old when they show first symptoms. There is a younger version, which is called juvenile. Average length of life from the very first symptom appearance to the end of life is somewhere around 15 to 20 years. It used to be 5 to 10. What does that say? If it used to be 5 to 10 and now it's 15 to 20, what does that tell you about what kind of difference early identification and starting to build programming around it could mean? Tell me what you're thinking about an old lifespan that was 5 to 10 years after diagnosis, and now it's 15 to 20 years from first symptom.
Someone's hoping there's better care, better treatment.
Mm-hmm. How we support people, how we recognize what's going on, and how we start to provide environmental modifications, care modifications, life modifications is making a difference. It is this kind of condition that you wouldn't wish on anyone. It makes it extremely difficult for the person to interact with the world around them in meaningful ways and understand the world around them in any kind of reasonable fashion. The kind of things that happen are so extensive. So it starts often with movement challenges where there's writhing or tremors or slower weird eye movements, impaired gait and balance, difficulty with speech and swallowing. And then we also, though, may start seeing episodes of disorganized thinking, not able to focus, perseveration on something, absolutely unaware of skill changes, slowed processing, difficulty learning anything new, difficulty with impulse control, difficulty even with visual regard and not making choices at all, just getting unable to make a decision, just stuck. Emotional changes, whether it's depression or social withdrawal, apathy. Now, what are you starting to notice with a lot of this symptom profile? Because I've been through like 5 of them now, and what are you starting to notice? God, there's a lot of similarities. That's why progression matters. That's why at first people may not be able to tell an atypical what it is. I'm not sure which one it's going to be, because it's not until it moves forward a little bit that we can start to wrap our heads around, okay, so this is starting to sort itself out a little bit. So I'm thinking it's more like this versus that. So what you may hear initially is, I think it's an atypical dementia. I'm not sure which one it's going to be. I think it's cortical, or I think it's subcortical, or I think it's substance induced. If I think it's substance induced, if I can do something about the substance, then maybe I can have some impact. So, this is where really, I mean, this is rolling dice and trying to figure things out. But if I'm the provider of support and care and I start to notice this profile where it seems like it's spreading and it's, now, what's the other bad news about 15 to 20 years? We're spending more time in the later state instead of dying prematurely, what we would have called prematurely, because I'm much better as a care provider at figuring out things that keep you from harming yourself or causing yourself damage. It doesn't mean that the quality of your life is what you would wish or I would wish. It can be a really difficult living, but it does last longer. Weight loss, loss of appetite. So what you will notice is some of these symptoms are similar with the progressive supranuclear palsy. And a lot of these, and I've given you some Huntington's clues. It's relatively rare, and there are still possibilities of people suddenly popping up because they've never had health care and their parents died of things when they were young, of other reasons, so we never knew about their Huntington's. And they might have had a female carrier where they didn't get the symptoms. It's sort of those weird ones, but most people with Huntington's are falling into groupings. We know where to look, we know where the gene code occurs. So it's less of a surprise. So they will do some genetic testing and often be able to discern what's going on. So if we see some of the symptoms, Huntington's will be something that, because it's genetically related, we'll be able to find it relatively early and know that's what we're looking at. And then having to deal with, it's relatively rare, having to deal with the consequences of knowing. Multisystem atrophy. Now, this one was called Shea-Drager syndrome because of the physicians who found it, but now it's called multisystem atrophy. It either has a Parkinsonian look to it or cerebellar look to it. It affects people in their 40s to their 60s typically. And 40 to 60, you either get multisystem atrophy that looks more Parkinsonian, so it has some of the cog-willing rigidity, tremors, some of the mask-like face, some of those kind of features, or it will be cerebellar, which is more of a gait disturbance. And also what you're going to see with these kind of things is what we call core brain dysfunction. So blood pressure changes, hypo to hyper. It can actually threaten your life and kill you, or it can resolve all on its own. So hypotension when you stand, no blood pressure to your brain, and you drop, or you're hypertensive when you're supine, and it can kill you because you become so hypertensive you stroke. You can have sweating issues where you just suddenly, you're sweating like crazy and you have freezing extremities because your brain cuts off all circulation to your extremities because you're doing all this heat distribution and it's coming out of nowhere. You can have what are called syncopal episodes where you have fainting episodes that come out of nowhere. You can have gasping or this sign phenomenon, sexual dysfunction, where I'm young, 40 to 60, and I have absolutely no sexual function. Episodes of off-center posture, so it's the Leaning Tower of Pisa phenomena. Now that can happen with Lewy body, and that's why it's tricky, but you can have some of these same symptoms with Lewy body. But if this is your primary profile, then we're looking at multi-system. But again, all related, just like Parkinson's and just like Lewy body, it has to do with alpha-synuclein malformations. Sleep problems with waking dreams, cardiovascular events, blood pressure problems. We can have emotional control problems, bowel bladder, blood sugar, motor control, swallowing problems, and severe mobility impairment are often very, very early in the disease, starting to happen with loss of communication. So somebody who has this, how many of you who might be having this are going, that looks like shit? Yeah, because I'm talking about a 40 to 60-year-old. This is not, this is one of those diagnoses where it's like, I don't want anybody to have this one. And I wish we had that kind of power and control because we would never make this choice for someone. So if somebody, we do want to know about could it be Lewy body, or could it be multi-system, or is it a combo? Could it be Parkinson's, or is it multi-system? Because what I want to think about it with the multi-system is, boy, I've got to build in a safety net that includes things like blood pressure monitoring at a different kind of level. Because when I say that you can lie down and you're in bed and it can kill you, it can kill you. Your blood pressure can get over 250. And you can go up over 250. I mean, and it's just, the blood pressure is so extreme you can't survive. And then on the other hand, your blood pressure could drop so far that if I don't get you back down and I don't get you into a supported position, you won't get blood flow to your brain. And you'll die because you don't have blood flow to your brain. So it does require, if I think you have multi-system failure, I've got to really be tuned into, I need a safety net as a care supporter. You need a safety net unless our decision is something different. Yeah, I did just say that. Unless our decision, like your decision and my comfort and my okay with that decision, is something different. If it happens, it happens. That is a decision that we need to talk about much sooner. If I know you have multi-system, then I would necessarily have this conversation with someone else. Because we need to know, I need to know, as your supporter, what is it, how do you feel, what do you feel about that? I mean, what do you want? I mean, what do you think you want right now? So I can get more comfortable with where you are. And I want to make sure that what we're not dealing with is this idea that, oh my God, if this is what is ahead. Well, this is sort of where we're heading, but not necessarily in a year. We're talking about over time. This could happen. And you have a lot of good time available, but these things are going to pop up. So are we going to deal with them, or do you just want to call it quits now? I mean, I'm standing here and I don't know the answer for you. What I do know is you deserve to be asked the question with the right support. And we do not classically, guess what? Talk about this stuff. You can live life quite a while with really good quality of life, except these things can pop up for you. And if I don't understand that, and I go into emergency reaction, but the emergency reaction is done with a system that doesn't understand your condition, I could put you through all kinds of prods and needles and checkouts when it's like, pause. What I need you to do is just right now, we need to manage the blood pressure right now, and he'll be fine in an hour. So let's just probably, and that's all I want you to do is manage the blood pressure. We don't need to do another full workup. We don't need to go. Stop, pause. I'm the healthcare power of attorney, and I might actually, if I was the person living with this, need a healthcare power of attorney sooner. Because tell me what that means when I'm telling you that these primary problems with homeostasis can happen at the drop of a hat. When you have this dysfunction, what does it mean you better have available at the drop of a hat as well? Because this is not usually something we have to talk about really early with most other dementias. What do we need to have here, though? I need a surrogate decision maker who understands what I want. I'm going to need a surrogate decision maker really early on, because these symptoms could put me in healthcare, put me in emergency care really, really quickly. And I could lose so many choices in where I'm comfortable, where I'm not comfortable, and what's going to happen to me. Because when these kind of things happen, people get really excited. This is the adrenaline junkie's dream. Oh my God, so many interesting things happening to you. Let's explore. And it's like, time out. No, we're done exploring. Here's the deal. And because it's an atypical, very rare dementia, what do you think that means? It's a zebra. Do you guys know about zebras and horses? Y'all need to know about zebras. If you've never been in a medical school, I taught at a medical school. Guess what? Everybody loves to come into the clinic. Guess what they love? Zebras. They love zebras, because horses are just horses. You get to know horses, you know, they're just horses. Zebras, though. Oh my God, how exciting are zebras. I can just cut my teeth on zebras. Now, you can cause a lot of damage on zebras is what you can do. You can put them out from the herd. You make them feel so weird. And what happens to the horses? Well, they don't get necessarily good care either, because all we're doing is calling the zebras. And what do we want to do with the zebras? Investigate. I want to get to see one because it's so rare. Now, I'm being a little bit mean, but I'm not. I'm being realistic. I've been around a long time. Zebras are interesting. What people don't understand is they're people first. They aren't zebras. They're people. So, resources. Post-cortical atrophy. So I'm going to pause here because I'm curious how many of you are just going, oh my God, does this ever stop? I mean, are you just going through like one after? I was like, yeah, when I was trying to write this, I was just going, it feels like it, but if we don't talk about what we're seeing and how we can support what we're seeing, we're missing a chance to support people where they are. And if what I'm seeing is an Alzheimer's, I need to quit saying the word Alzheimer's. If what I'm seeing is an atypical dementia, I've got to sort of call it like it is. And if I see something that just doesn't fit the pattern, rather than trying to push people back into the pattern, I want to notice what seems to be different. That means we have 10 minutes left. I know. Look how much time you spent here. It's almost, you know, like we spent all this time and I've only covered a few. This is another tricky one in that it used to be called Benson's disease. And so some people are still calling it Benson's disease. Most people aren't, because now we call it post-cortical atrophy. Who will be calling it Benson's disease? So if somebody keeps talking about, well, I think you have Benson's disease, I may want to get a second opinion. Because if they don't start saying, it used to be called Benson's disease and now it's called post-cortical atrophy, I want to know whether they're keeping up with the latest idea of treatment and how this might happen. So when you look at my second point, it can have more alpha-synuclein protein malformations, tau pathologies, and beta amyloid abnormalities. So depending on which one it has more of, it may look more like a Lewy body disease or an Alzheimer's disease or a corticobasal pattern. So this one is a little tricky. It tends to happen to people from 50 to 65. So that's sort of the age range when we see this one starting to pop up. Almost always visual disturbances or visual issues will happen. And what's tricky is it can look like one thing and then it starts looking like another thing and then it starts looking like a third thing. And so if you look at the laundry list down here, visual spatial object recognition problems, apraxia, I start to have motor planning problems. I'm having trouble with my eye-hand, how I go to do something that I've always done without thinking. Now I'm having some trouble. I'm having trouble with facial recognition software. I can see a face, but I'm having a trouble putting it together into a recognizable face. I'm having trouble with vision perception. So I go to reach for things or do things, and I'm having difficulty with getting things to fit together, 3D images coming alive, and drawing even a 3D image. And I might have been really good at it. Now I'm struggling to do that. I'm having trouble in the mirror. Even though I've never had trouble in the mirror, I might be having a lot of trouble working in the mirror. So we were looking for a change in ability. Getting lost, having a difficult time finding my way around, or getting in environments and feeling like, what the heck? Where the hell am I? How did I get here? What's the name of this? What am I doing here? Reading and writing skills might really significantly decline. My eye-hand coordination might change. It may feel like really awkward. I'm having trouble using numbers. I used to be really good at numbers, and now I'm having trouble, like, how many is that? And how do I manipulate these numbers depending on my basic skill set? And I have trouble sometimes getting my eye muscles to cooperate and coordinate with me. And people often describe eye fatigue or problems with my eyes, just rubbing the eyes, feeling really frustrated about using your eyes. So here are some resources. So the management, the support would depend on primarily which of these patterns you start seeing. But what's really important to notice is this posterior cortical atrophy, there's a lot of visual stuff going on. And it is a little tricky, but it's not just visual. It's visual and spreading around to the parietal lobes. and to the temporal lobes, and then starting to impact the front. So it is coming from the back of the brain forward. So in the last couple of minutes, after all this, why would you bother and why would you care about getting a good and complete diagnosis? Well, here's why I recommend it. Because I think future planning, we want to know progression and prognosis. Finances can be a huge issue. Other health issues or health concerns. Staying in control. Well, we try to stay connected in our relationships for these kind of things. The more people around us understand what's going on in us, I believe it can change dynamics, but it still isn't easy. I'm not saying it's easy, but it changes things when I know, wow, this is the degeneration you're living with. So now it's the degeneration I'm living with. So sometimes skillful and careful use of medications can make a difference. Sometimes really understanding that medications are not the answer for this particular issue can make a difference. Because then I get committed to, okay, so it's not going to be a medication. That means it's the environment, it's my expectations, it's my skill set, and it's my programming. That's what is going to make a difference for me. I've got to change other things because the meds are not going to be the answer. God, man, if I could just take the silver pill and make it all be better. But it's probably going to be more complicated. So now comes the time when we really want to appreciate this stuff. Not to feel sad, but to feel empowered, to have compassion, to be curious. And most important, to recognize, wow, if that's changing for you, I've got a lot of changing to do. I'm going to really work on things that I think are going to empower both of us to do something different. And what that means is I've got to be willing to try something new. And I've got to be willing to learn something really different than what I thought I was going to learn. And I've got to be willing to see things from somebody else's perspective. And I've got to be willing to fail. Because that's what's happening to my brain. So I need you to be willing to fail alongside me and be sorry. I'm sorry it happened. I'm sorry that went that way. I was hoping for something better too, but be willing to try again. And this is essentially true whether you're the person living with dementia, the family member or friend who's trying to help, or a professional who's trying your damnedest to do the right thing, but you're going to make mistakes. Get over it. Because mistakes happen. It's only when we don't learn from what doesn't work that we commit ourselves to repeating something that doesn't make a whole lot of sense. But the tricky part is just because it didn't work this morning doesn't mean it won't this afternoon. So I've got to be committed to trying it enough in different situations that I figure out the specifics in which it might work and the details that help me know when it doesn't. So I am hoping that our time together was valuable, that you got something from it, that you're walking away with something you can use. So if you have a few seconds before we take leave of one another, we have about 4 minutes. If you want to put anything in chat that you're thinking, feeling, wanting to share, questions that you still have, I mean, if there's anything that I could do that you feel would have been more beneficial or that you didn't hear that you really want to get, please let us know. Because I did the best I could with a subject that is this big when I had this much time, but you know what? That's the time we had. So I tried to cull from it what I thought people might benefit from, but if I made a mistake, I'm sorry, because I didn't do it on purpose.
We have a couple of questions of different conditions, and I'm wondering if they are related to dementia. Spinal meningitis, have you ever heard of that being in connection?
Yeah, so people who experience a spinal meningitis, there is a possibility with more recent research that says they may have an increased risk of developing dementia at some point in their life. But we don't know that. But we do know that what that tells us is a viral agent got into the system that should have been protected. And it got through the meninges, that covering, and it's on the inside. It inflamed it, and it crossed that barrier. So, ooh, now I'm worried a little bit because that virus may have put little things in there that can trigger a cascade. And that's what we're starting to understand. Inflammation, irritation, that constant kind of thing that maybe at some point it's the thing that triggers us into the cascade of a dementia is really where we're at. So maybe increased risk.
And same with like ADHD or Graves, Hashimoto's.
Okay, yeah. Now ADHD, we're starting to learn something about ADD and ADHD, which is the wiring of that brain is different wiring. So if we learn to adapt and adjust and we get the normal going on in that brain, and so the world isn't overwhelming and frustrating, then we have a better chance of not having a whole lot of cortisol floating around in the system and not having a whole bunch of adrenaline and a whole bunch of anxiety and a whole bunch. If we can do that earlier and help us stabilize things earlier on, we don't know what the outcome will be, because guess what we've done so far? Push people with ADHD and ADD into a box that says, not normal, not normal. We've got to fix you. We've got to do things. As we're learning, what we need to do is change the environment, change the expectations a little bit, set up this sort of system where they get the right support at the right time. We don't know the answer, but we suspect that this current group that I'm in, baby boomers, there's a very high risk that baby boomers are going to experience some things that were because we insisted that people fall within the bell curve. Graves' disease, that's that thyroid issue where we have problems with thyroid function. It relates to thalamus function, and so we are just beginning to explore that, because what it says is inflammation, irritation, maybe, yeah, there might be some relations, but we're just starting to really understand it. Anything that has an acute episode, though, that causes brain shifts puts us at ill at ease these days. That inflammation thing, that irritation thing, that, okay, it got in there somehow, let's figure this out, might be something to be aware of and cautious about. So thanks, everybody. Go take care of yourself for just a few minutes, so that you can go to your next session. Now, those new sessions, we are going to try to get everybody possible over onto Zoom, if at all possible, so that you're going to be able to participate more actively, if you'd like. Now, I noticed a lot of you didn't want to participate very actively, but, you know, we're asking questions. It's all good. All right, everybody, be well. We'll see you in a little bit, or enjoy the next session wherever you go. Thanks, Polly. Thanks, Emilio.